can you please also stand up and read this clinical unit?
A 35-year-old male living in Karachi presented to emergency department 2 days ago with complaints of pain at the right flank region and towards the lower abdomen. Pain was sudden in onset and pain is so severe that patient cannot stay still. His sleep and daily activities were disturbed. Patient also has an episode of nausea, vomiting and sweating. Patient has a fever, burning sensation during voiding of urine and urgency of urine. Urine analysis shows increased loss and microscopic hematuria. Plain X-ray abdomen shows a large radio-opaque shadow in the renal calyces. His father had the same condition in the past.
Very good. So what is the diagnosis?
So this is the picture of your patient. He was complaining and he was
tell me.
So what your most likely differential diagnosis is this thing? You can single out.
Also, can you? What is your diagnosis?
According to this scenario, it may be renal calculi, it may be ureteric calculi.
How you justify it?
Sir, right flank pain.
So what is the association of Karachi with this pain? इसने specifically Karachi का नाम लिया। कुछ है एसोसिएशन वजह आपके जहन में आ रही है? यहाँ पर आप और
Sir, hot weather.
Can anyone tell one more differential diagnosis of this man?
So your diagnosis was renal calculus?
Yes, sir. Good.
Right. Any other?
Answer? Ali, can you please stand up and tell the another one differential?
Why renal calculus? At least left and any other points?
Thank you, Ali. Please sit down.
How you justify that is a renal calculi? Why not colonic cancer? Funding the because of the inflammation of urothelium. And their urine analysis shows a lot of pustules and RBCs. And there is radio opaque shadow on KUBS at the renal medium. These are the points that justify most likely pathology is in the kidney, not in our system. Right.
So diagnosis of this clinical related renal stone, and specifically the stack-on stone, which are present in the renal calyces. Therefore, so other name for the renal stones are the kidney stones, nephrolithiasis, urolithiasis, and the renal calculi. These all names are used for the kidney stones. Renal stones, first of all, are the aggregates of crystals which contain the protein and glycoprotein. Its prevalence is only 2 to 3%, and it affects mostly men more than the women, and mostly 20 to 50 years of age. Yes.
So the most common age group is
20 to 50.
50 to 50 years of age.
So mostly these stones, there are 3 areas where these stones formation is occurring. Stone in the ureter, stone in the kidney, and stone in the bladder. These 3 more specific areas where these stones
Where you will find kidney stones.
So how urine crystallized? When dehydration occurs due to the decreased water content increase in inorganic precipitates occur. Therefore, you will crystallize in this case.
So why patients get renal stones? You can ask from them. Why? आप बताइए
Increase water intake
and
and increase
so what will happen if there is decreased water intake? What will happen? All the solutes present in the kidney will start precipitate. There will be crystallization, and this is the initial starting of the stone formation. So crystals deposit, and there is sedimentation and precipitation, levelation.
So there are 4 types of main stones. We discussed each stone, some characteristics and some causes. So major chunk of this stone is calcium stone. Next.
Calcium. Where is calcium stone? Where is the major chunk? Okay.
This one is the major chunk.
Yes. This is.
Calcium stones.
This is the reason 80% of your calcium stones are radio opaque on X-rays. This is the reason. Because it contains 80% calcium. But if your patients have uric acid, they have only 7%. So what you conclude from this data, the 80%, 80 to 90% of the stones are radio opaque, and 7% they are radio lucent. And in case of gallbladder stones, how much percent of gallstones are radio opaque and how much are radio lucent? 95% are radio lucent because they are made up of cholesterol. So cholesterol is radio lucent. So if there is a calcium bilirubinate deposition, it will only be radio. So 5% radio opaque and 95% are radiolucent in case of gallstones. But converse is true with kidney stones, reason being higher calcium concentration.
So first of all, calcium oxalate stones, these are the most common as we discussed, 85%, and it is most common in the adults. The next one is common in children, we will discuss later. Some characteristics of these stones are, they are irregular in shape and it has a sharp projection, and when these stones deposit in the kidney, it can cause the bleeding because it has a sharp and irregular edges, and specific color, black and dark brown color is present, and it causes the acidic urine.
So this will form the acidic urine.
So next one is the calcium phosphate stone. This is most common in children. The previous one was in adults, and these stones are lesser in amount than the calcium oxalate stones, and these are mostly the dirty white, and it can cause the alkaline urine. Previous one was caused the acidic urine.
So from here, you can pick one point. What is the commonest cause of calcium phosphate stones in children?
milk.
Solitary?
Soil.
Solitary means
Matti.
वही रोटी खाने से कुछ नहीं होता।
Milk. Calcium.
रोटी खाने से कभी कोई फर्क नहीं होता। ये याद रखो मीटिंग में। जाके नहीं आया तो आज से ट्राई स्टार्ट करके बोलते हैं। सारी मट्टी खाने से। But ये अगर learning मट्टी स्टार्ट कर we are talking about second power का epithelium of your small intestine Ilaj। ठीक है, minerals की बात में जो चीजें मट्टी से नहीं होता। What is the reason? देखो एक छोटे बच्चे हैं सारे। एक नहीं, if there is a stone formation, what is the underlying pathology? No. 5 साल के बच्चे stone formation. कल भी मैंने इसको काफी डिटेल से बात की। What is the commonest cause of stone formation? Especially this type. Stasis, infection, stone formation. So what will be the reason?
Sir, upper respiratory
Underlying congenital anomaly of the renal tract.
Yes.
Inadequate drainage of urine. Congenital pelvic junctional anomalies. Urinary anomalies. Urinary bladder anomalies. There will be stasis and stone formation. The commonest cause of stone in small little kids is and they are found in alkaline urine. And uric acid is found in acidic urine. And calcium oxalate acidic urine. Next.
So next one is the screw-white stone. These are also called the largest renal stones or infected stones. Basically, it can call the screw-white stone because it has a magnesium ammonium phosphate is present, and it is also called the staghorn stone, like the staghorn of the deer. It enter the renal pelvis and branch into the renal calyces, and there is specific color of the stones, dirty white, and it is very smooth stones.
The stone is not entering into the pelvis. They are formed in the pelvis. And they form it into major and minor calyces. So these are the calyces and the distribution. And they are still and they are also known as triple phosphate stones. Calcium phosphate, magnesium phosphate, ammonium phosphate. This is the reason they are called triple phosphate, screw-white. And they are only found in infected urine, not sterile urine. So which one is found in the sterile urine? Uric acid stones. Then the metabolic stones, they are found in sterile urine.
Next one is the uric acid stone. These are multiple stones which irritates and very hard and smooth. And some stones are very rare, like the steam stones and the theme stones.
Why patients get uric acid stones?
So uric acid stones specific प्यूरीन रिच फूड से गाउटी आर्थराइटिस से हो सकते हैं. इसके अलावा leukemias, respiratory disorders.
Purines and pyrimidines. End product is uric acid. So if there is an anomaly in the enzymes, anomalies in enzymes. So what about cystine stone?
We will discuss about the etiology of each stone.
So the rare form of calculus is cystine. ये आपने कम ही देखेंगे. Hexagonal, translucent, white crystals. आप इसकी original pictures आपको नहीं मिली. तो sketch है ना. Original pictures भी आपको मिल जाती हैं. ज़्यादा idea होगा. And xanthine stones. अब ये बताएंगे cystine stones क्यों बनते हैं और xanthine stones क्यों बनते हैं. यूरिक का हमें कुछ idea होगी. Yes.
So first of all, calcium stone etiology is it may be idiopathic. There is no cause, and sometimes either may be increased calcium amount in the urine or either in the blood, and it can also be due to the primary hyperparathyroidism. This picture has shown the 4 parathyroid glands. It can also be due to the sarcoidosis, and more specifically, calcium phosphate stones are occurred due to the renal tubular acidosis type 1 and type 2 due to the impairment of renal tubular absorption.
So the purpose of the calcium stone formation is idiopathic, not like and second is urea. What is it by there? Hyperparathyroidism. What happens in hyperparathyroidism?
Mobilization of the calcium from the bones and
Calcium from
bones and
increase absorption of calcium from kidneys
Intestine.
and GI. So what is the net outcome? Hypercalcemia. And that will be filled through kidneys. So the kidney filter is basically clogged due to hypersecretion of calcium. So there is stone formation. What is the renal tubular acidosis? Type 1 and type 2. This is the two way.
Salam.
Kala, who is Kala?
Actually, there is too much bicarbonate in blood.
Acidosis.
Too much
Is it idea?
too much protons in urine.
You are telling me or asking me? watching and ignorant. Any idea? है किसी को आइडिया है? आप में से किसी को आइडिया है? renal tubular acidosis?
Sir, due to the impaired renal absorption.
कोई convincing answer दे। नहीं पता है तो आप बात पे जाके पता करें। लेकिन information सही है तो दे दो, नहीं तो do not spread wrong information. That is the right information. Are you sure? What is that? Cross check करेंगे. If information is wrong, you will be penalized. Yes.
डिस्टल ट्यूब्यूल्स में जब पोटेशियम और हाइड्रोजन की कंसंट्रेशन बढ़ जाती है तब रीनल ट्यूबुलर एसिडोसिस होता है।
Record कर लिए? This will be used as a weapon against you. Videos are considered as authentic documented evidence in the court of law. Right. Go ahead.
Next one is the calcium oxalate stones. It may be due to the primary oxaluria, due to the enzyme deficiency, or maybe due to
Primary oxaluria. Which enzyme is deficient?
secondary hyperoxaluria. This may be due to the Crohn's disease, thyroid disease, gastric bypass, or defective liver metabolism. And there are some foods, oxalate with foods. There are pictures shown there, like spinach, bark, it is like chucandar, and too much dry foods are taken, dark chocolates, black tea, french fries, and beers. These are all are the oxalate with food and oxalate with foods, and these can cause a calcium oxalate stones.
Which tea?
Black tea.
Black tea. And which one is?
Beer.
So they are oxidations of
Oxalate with
oxalate stones. Dark chocolates.
Next one is the uric acid stones. The most common cause is gouty arthritis and too much the allopurinol use because and there are myeloproliferative disorders like the leukemias and some obese patients like diabetes and there is decreased pH due to the and then some urine rich foods like red meat like beef, chicken and
Chicken से तो नहीं होना चाहिए. Chicken is white meat. Too much of chicken.
and shellfish.
Too much of.
There are the urine rich foods and this can cause the uric acid stone. And there is some pathology behind it because uric acid lose proton and become the monosodium urate crystals which are also formed in the gouty arthritis and deposit in the first metatarsal pressure joints.
Monosodium urate crystals हैं.
सर
Questions बाद में.
Triple phosphate stones, also called the screw-white stones. There are some causes which are the urea producing bacteria. These are the least. Proteus mirabilis, Proteus vulgaris, Morganella morni, Klebsiella pneumoniae, and Streptococci.
So which stone is more common? This one. Triple phosphate stone. This is very common.
It can also be due to the red meat. And there are risk factors behind this stone like the UTI, zygote-ureteral reflex, and obstructive neuropathies. Because this enzyme converts the urea into ammonia and carbon dioxide, and ammonia causes the alkalinization and precipitation of urine.
So what is the reason of triple phosphate stone at the top is? So what are the uropathogens responsible for stone formation? Mirabilis, vulgaris, Klebsiella. ये याद रखें, तीन तो याद रखें. So when you culture patient with UTI, secondary to Stegron stone, you will isolate these three bacteria, and they are known as uropathogens. Their favorite place is urological tract. In staphylococci, this is only possible when you catheterize patients. Hydrogenically, otherwise Staphylococcus aureus is not a uropathogen. It is normal inhabitant of your epidermis in the skin. So if you try to find Staph aureus, either this patient is catheterized or the instrumentation has been done, and this is the reason. So due to meat.
Next one is some enzyme disorders like the xanthinuria and cystinuria occur due to the genetic deficiencies.
Again, we are talking about amino acids.
Other causes are the people living in the hot climate like the Pakistan. It is very common, 8 to 10%, and Saudi Arabia is also a hot polar climate. And there is also due to the dehydration, less water intake, and salt intake is the less. These are the amount. And people are increased production.
South Punjab or North Punjab, Multan, ये वाला एरिया जो है यहाँ पे बहुत ज़्यादा गर्मी होती है, यहाँ पे वर्कर को बहुत स्नो फॉर्मेशन, राजस्थान का एरिया जो है हमारा 24 salt intake.
It can also be due to the excessive use of anti-cancer drugs, chemotherapy, loop diuretics also cause the dehydration. And
What is loop diuretic?
Yes. Can anyone tell the one loop diuretic?
furosemide,
Furosemide.
legiskinase.
Furosemide is loop diuretic. It will increase the concentration of water there to stop injurious fluid.
It can also be due to the vitamin A deficiency or the vitamin C, D, and calcium supplementation. And it can also be due to the decreased urinary citrate formation. And it can also be the genetical, it runs in generation from parents to children. And it's more common in Asia and Europeans. And some congenital anomalies like the medullary sponge kidney and cystinuria.
So what is the association of vitamin A deficiency, vitamin C deficiency, and calcium deficiency leading to stone formation? What is the role of vitamin A? Vision. Yes, very good. So vitamin A is very important for the healthy basement membrane. So when it comes to kidneys, if you see the longitudinal section of the renal tubule, the tubular cells are basically simple cuboidal epithelial cells, and they are resting on the basement membrane of the tubule. So what will happen if your patient is vitamin A deficient patient? These cells will not be properly attached to the basement membrane. They will be dislodged. They will be plucked off. They will be dropped into the kidney tubule. It will go down 1, 2, 3, and then they are going to block the flow of urine. So as a result of that, when the urine is blocked, the calcium in your circulation is going to be deposited around the shedded epithelium, and that provides the nidus for the formation of the stone. So this is the reason vitamin A is responsible for stone formation.
So clinical feature, some patients are asymptomatic or these are most common the right-sided or unilateral stones, 80% of the cases, and it can cause a dark yellow urine, and it can also cause the hematuria, blood in the urine, and pyuria in the case of white stones. Like white stone has a fever occur, urgency, frequency of urine.
You see which stone is asymptomatic?
Liver stones.
And triple positive. Why?
They are in the
They are in the pelvis space, right? They are not going to outlet.
Okay.
And the commonest pathology, commonest side is right side. 80% on the right side.
Can anyone tell what is the urgency of urine?
What is?
Urgency of urine.
Patient has got small volume of urine, but he has strong urge to voiding. Volume is small, but he frequently goes to voiding. This is known as urgency. We cannot hold it. The abdominal muscle is going to contract because of irritability of the urine bladder.
And in the uric acid stones, there is a pain in the big toe, in the first metatarsal failure joints, and there is also vomiting, nausea, and sweating occur.
Vomiting, nausea, and sweating. If there is stone. So vomiting, nausea, sweating. This is a feature of either an episode acute pain or a sign of chronic renal failure.
It has a specific pain, it is called the renal colic, and acute loin pain. Patient may present in the pain in the flank region and from the side between the ribs and vertebrae, and it may radiate anteriorly into the groin, lower abdomen, testes in the male and the labia in the female. It mostly occurs in the ureteric stones, and some patients also present with the urethral pain and sometimes no pain is present in the kidney
So how
stone.
you describe, how patient will describe urinary pain? If it is acute urethritis due to stone in the kidney, but the bacteria and infection is going to inflame the urethra, the patient will give you information that I am like, passing boiling water. This is a characteristic picture, boiling water, and we call it burning of punctuation. So boiling water is a sign of acute urethritis, and this inflammation, this infection is basically secondary to renal infection. So the whole tract is infected, and this is the reason. No matter where it is known, these patients usually present to you with the signs and symptoms of urinary tract infection, so UTI. So you have to diagnose in the case of UTI, where actually is the pathology in the kidney, in the urinary bladder, why this patient has got UTI. So you have to find the cause. So urethritis, severe dysuria, patient is complaining of like I am passing boiling water, hot boiling water, per urethra.
The pain is some specific characteristics. Pain is dull, localized, sharp at the area of the stone, and sometimes in the quality it will increase or decrease, and sometimes it is more severe that a patient cannot stay still, and these pain, mostly stones are present in the pelvic urinary junction. And why this pain occurs? The pain is due to the dilatation, stretching and spasm of the muscle due to the stone or due to the urinary obstruction.
Now, you see, this is very important. If the patient has got no blockade to the flow of urine and stone is silent in the pelvis, there will be no problem. Patient will be asymptomatic. There is a big stone there, but they are asymptomatic. But the moment it is going to block the flow of urine, the major calyces are from pelvis into the ureter, there will be signs of pain. Now, what will happen? Patients with pain in the kidney, they usually present with the spasm of the overlying muscles as well. They hold it this way. What is the reason? Because of the overlap of dermatomes. So patient will be having spastic muscles and they are in severe pain. So the moment channels are blocked, the dull constant ache will be transformed into polythectic, because the muscles are going to contract against the stone. Muscles, no muscle after tries to expel the stone out. As a result of that, there is severe spasm, and that will lead to localized ischemia. And ischemic pain is one of the severest form of pain.
So how will we investigate this stone? First of all, we will do the urinary routine examination, and there may be the RBC hematuria due to the injury by the stones, and it may be grossly visible in the urine or it may be visible in the microscopically. And if the stromoid stones are present, there will be UTI and the bacteriuria is present and mucositis are also present.
So urine sample has to be grossly examined. You see this will be the color of urine. But if a patient presents with dark color urine or red urine, you do not jump onto the conclusion of that there is stone inside. There are so many other causes of red urine. What are the other causes of red urine? You have to keep your mind open. Number one,
Nephritic syndrome. Nephritis syndrome.
glomerulonephritis,
Nephritic
nephritic syndrome,
Sir, rifampicin if he is anti-tuberculotic.
anti-tuberculous rifampicin, very good.
Hemolytic uremic syndrome.
Urothelial carcinomas, transitional cell carcinomas, hematuриas, and if the patient is on blood thinners like warfarin, like aspirin, like clopidogrel, and patient has got any systemic illness, any other urological factors and medications. Next.
We can do some other investigations to rule out the cause of these stones, like renal function test to select the 24-hour urine collection, and we may see there will be the creatinine and blood urea nitrogen will be high, we can check some electrolytes imbalance, like we have discussed the sodium level and potassium level, and then we can check the pH level, pH level, and pH levels, spirit levels, and also spirit.
Power of it all on hydrogen is the pH revenue all of hydrogen concentration.
And we can check also the citrate levels.
Citrates are pro-stone or anti-stone?
Anti-stone.
This is the reason you got this term from citral. So citrate inhibits stone formation. So citrates are low. You have to increase the level of citrate. Disintegrate in our organic system. That is making the organism more prone to liver.
We can do the CBC to check the WBC count and to see the infection, and there are some indications for this investigation. We can do in the asymptomatic patient, and we can also do these investigations after the 1 to 3 months after the acute stage, and if the acute kidney injury is present, then we can do this investigation. So we can check the specific levels like serum calcium and serum uric acid, and also the bicarbonate and phosphate levels to rule out the calcium oxalate stones, uric acid stones, and phosphate stones.
So specifically, if you want to exclude calcium stones, you do serum calcium levels. And normal values of calcium in your blood is 10 milligram per DL or 10 milligram per cent. But if it is more than that, you are vulnerable for stone problem. Uric acid normal value is this. If it is more than that, uric acid stone. Bicarbonate and potassium, calcium phosphate stones.
So we can do the chemical analysis of the stones. We can do this investigation after the surgery when we remove the stones. We can check all these stones like calcium oxalate, phosphate stones, and we can do the microscopy of these stones. And like we have discussed previously, there is specific shape of these stones are present, like hexagonal cysteine stones, phosphate stones, uric acid stones.
So if you do microscopy, you will find calcium oxalate crystals and uric acid crystals, phosphate crystals, hexagonal cysteine stones. So simply looking at the crystals under microscope, you can diagnose what type of stone is there inside. Right. So what is the hexagonal? If you will find hexagonal crystals, what is the stone in between? It is cysteine.
Then we can do the radiological investigation. First of all, plain X-ray we will do, and the X-ray of the KUB, kidney, ureter, and the bladder. And if the patient, it is the most the initial investigation, and mostly 90% of the stones are detected in this X-ray, because mostly 90% stones are calcium stones, and these stones on the X-ray and the radio opaque area like calcium oxalates, white, and phosphate stones. But some stones are the radiolucent, which cannot be seen on the plain X-ray, like the uric acid stones and cysteine stones. Like you can see in this picture, these stones are present in the renal calyces and with the white stones.
This is the KUB X-ray of Where is the human urinary bladder located?
Can anyone tell where is the bladder located?
In this X-ray. आइडिया किसी को भी नहीं आइडिया
नहीं सर है नहीं है सर है नहीं
है ही नहीं तो आपका फोन करो
वो नीचे
हाँ मैं इधर इधर एरिया
तेरी
माई क्या करने की
there.
This area is the area of urinary bladder. So this is not visible. If there is a stone there, it will be visible. Now you see, do you think pubic symphysis is visible here in this X-ray? So technically speaking, this is not
Abdominal leg.
if pubic symphysis was visible, a small part of say 20 or 15% of urinary bladder is excluded from the field. So pubic symphysis has to be visualized. Only then you will say this is a KUB X-ray. Otherwise, this is X-ray. So what you see is so X-ray KUB is showing a radio in a shadow onto the right side, just lateral to which vertebra? You start counting from below up.
Yes.
1 and 5, 4, 3, and 2. So what you will say? Between L2 and 3, anterior to the transverse process of L2 and 3. There is a big radio opaque shadow. And what is this black shadow? This black shadow. This one. Which part of the large is this? Ascending. This is ascending column. Very good. So ascending column is having air in it, and the stone is behind it. So this is the reason. So before doing X-ray KUBs, you have to prepare your patient for this X-ray. So how you prepare this patient? The night before, patient has to be given lead therapy and purgatives, so their large gut will be free of air. Only then you will see small stones. Otherwise, little stones are visible. Small stones cannot be visualized due to distended colon.
And then we can do the ultrasonography, and first of all we ask the patient to drink plenty of water, and when the evacuation infection occurs, we will do the ultrasonography, and mostly the calcium phosphate or sulfide stones are detected on ultrasound, but uric acid and cystine stones are not detected. And as we shown in the picture,
Uric acid stone and cystine stones are not seen on ultrasound. Yes. They are not seen on X-ray. They are detected on ultrasound.
so here is the calculus present and here is the kidney. So there are some indications for the ultrasonography. If X-ray fails or asymptomatic patient we can do, and if the patient is unstabilized or ionizing radiation we will avoid, and that if the patient is pregnant or if the children are present we can do, and if the patient has a hydronephrosis or a swollen kidney.
Now, why ultrasound is important? In case of these twins, if the patient is unstable, patient you want to. So why unstable patient is not an ideal candidate for X-ray KUB? Unstable patient, for that you need to have a static patient, right? And the second one is you do not want to expose your patient for ionizing radiation. X-rays are lethal. And if the mother is expecting, lady is expecting, pregnant, female patient do not want to expose her ovaries and growth baby for ionizing radiation. That's another indication. And avoid X-rays in children. If you see bruise, blades are growing, if you will subject them to radial ionizing radiation, because problem. So indications of ultrasound.
Then we can also do the intravenous urography, and it is most commonly also used.
What is the sole function of intravenous IVU? Why you do IVUs? You want to look for whether the kidney is functioning or not, because these stones they usually damage the kidney and patients they present with renal failure or non-functional kidney. So we want to look for the function of the kidney. X-ray, KUB and ultrasound will only tell us the presence or absence of the stone, but this will not tell us whether the kidney is secreting urine or not. So in order to look for that, we use intravenous urography.
So we will check the renal functions before performing the intravenous urography by measuring the GFR with the 99 technetium PDPA renal scan. Can anyone tell what is DDP.
Diethyl.
DDPA scan depends on what?
Sir,
Can anyone know?
Anyone?
एंड पे सर इसके पेंटा एसिटेट है.
Yes.
So this is
Diethylamine pentacetate.
triamine pentacetic acid. Acetic acid. This is our acetate. This is the skin that is reserved for percentile function of the kidney. What is it, Ajay? Normally 50% this kidney is working, 50% this kidney, 100%. And if one kidney is diseased, or both are diseased, both have kidney stones, you want to know which kidney is functioning better. Obviously, you need to know it in percentage. And this is the percentile difference that will dictate your future plan of action. Right? So DDPA scan will tell you exactly that the right kidney is functioning, say 20%, 30%, 50%, and the contralateral one is 10%. But if the patient has got less than 20% or less than 15% of kidney function, you do so. But in the treatment of choice, you have to remove the kidney. There's no need to preserve this kidney. So this is the reason for the DDPA scan. So before going to DDPA scan, have you seen intravenous urography pictures of radiographs or films? So we can inject a dye, not dye, a contrast
Urography.
like this. Yes. Yep. So how you do this idea?
First of all, we inject the dye and X-ray is taken and next.
It's not dye basically, it's a contrast. It's crystal clear fluid. But when it is exposed to X-rays, it will be white. And this is known as contrast. So go back. Right. Few slides. So you inject into the veins, right? And patient is lying on the X-ray scope. And this will be the picture. And this is IVT. IVT stands for myogram. Because over here they are just displaying the pelvis of the kidney. So initially, contrast will be filtered through the nephron stage. In post-injection, after 5 minutes, it will take a snap. Okay, but structure will be displayed. Post-injection, just 5 minutes. Which area will be visualized on X-ray? Only kidney, because dye is in the renal tubules, and this phase of IVU will be known as nephrogram phase. Now the dye is after say 10 minutes or 15 minutes, you take another snap. So meanwhile dye is concentrated in renal, pelvis and major and minor calyces are displayed. And this phase of IVU will be known as pyelogram. Right? Now the dye is coming down into the ureter. And this will be known as ureterogram. And now the bladder is full. You will call it cystogram. And if you want to see whether urethra is obstructed or not, what you will say, what you will do? Urethra, normally urethra cannot contain or accommodate urine when you are resting. Do you have containing urine in the urethra? It's not possible. So you want to see the blockade. What you will do? When you will take an X-ray, you want to look for whether the urinary bladder is filled, and this column is also filled. And there is column of contrast in the urethra. So what type of procedure and what advice you will give to the patient, and meanwhile you will take the snap?
MCUG.
पानी डिश में कहीं घर जाके वापस पानी पी लिया शाबाश
Sir, we would ask him to micturate as उसी वक्त
this is known as micturating
urethroplasty.
you will ask your patient to stand up and you micturate, and a good and click is needed, and you see the urinary bladder along with urethra. So if there is any blockade in the urethra, you will see the mid of the shaft is blocked, approximately it is stagnant. And that is known as maturating cystole and urethral. And collectively from minor calyces down to maturating cystole and urethral, we collectively call it intravenous Euro. So if you fragment it, it will be nephrogram, pyelogram, urethrogram, cystogram, and urethral. Right. So in this X-ray, what you see?
So as we go, first of all, in the kidney, the renal pelvis, then into the ureter and the bladder. But if the stones are present, like in this picture, the contrast will not go further into the ureter or the bladder, and it will show the stone area.
Stone area, you will see where is the exact location of the stone in this particular position on the left side. Where is the location of the stone? Yeah, can you answer the question?
Can anyone tell where is the location of the stone?
यहाँ से पूछिए इस नाम पे पहली बार
Sir, Samra.
यहाँ पर stone on the left side, stone to the right. आप एक अकाउंट कर सकते हैं किस पर्टिकुलर के किस लेवल पे जो भी स्टोन उसने मार्क किया हुआ है ये कौन सा किस्म है नीचे है तक 5 की वजह नीचे 5 4 3 2 and 3 के साथ तो पर्टिकुलर हमेशा यू हैव टू काउंट फ्रॉम बिलो
5 4 3 2
But as you see, what is the difference between the kidney on the left side and the kidney on the right side? If you study that radio opaque phenomenon, the left one is they are dilated. So you will call it left sided pyelonephrosis due to stone in the upper 1/3 of the kidney. Ureter. Pelvic ureteric junctional kidney is there, and it has blocked the flow of urine, and patient is having a dilated kidney and dilated minor and major calyces. Good.
Then we can do the non-contrast helical CT, and it is the most accurate investigation. And
Helical means like DNA helicals, ribose and base, minor base. Helical means spiral.
So we can check in the CT scan like location, density, and the composition of the stones specifically. And most commonly the calcium, oxalate, and phosphate stones are highly dense, and all other stones are less than as compared to the calcium phosphate stones.
So highly dense stones. अगर आप X-ray करेंगे and the stone is very wide, it means density is very high. So this is very important. If density is very high, your treatment strategy will be changed. These dense stones are not amenable to extracorporeal shock wave disturbance. They are very hard stones. They will not break, right? And if it's uric acid stone, cysteine stones, and fluoride stones, they are since not visualized on plain X-rays. You do these helical CT smaller than 5 millimeter of stone will be detected by these CTs. So this is a gold standard for neurological stone evaluation.
So here is the stones are present in the CT.
अब बताइए किस चीज़ की है इमेज है जैसे MRI और CT scan. CT scan, okay. Now, which one is the right side of your patient? Your left side. Because liver is on the right side, right? And spleen on the left side. So what you see here, hyperdense, rather it's more dense than the body of the lumbar vertebra. You see here, if you compare that stone with the body of the vertebra, this is more dense. It means it contains more calcium than your bone. So this is very hard calcium oxalate stone.
So how you will treat this patient? Treatment mostly depend upon the size, site, and the composition of the stones. And mostly patients are managed conservatively.
Go back to previous slide. Now you can ask patients, students, what will be the treatment option? After the treatment, what is the existing knowledge?
Can anyone tell what is the treatment option?
How you are going to manage your patient with the renal stone?
Rules.
जब आप समझे कि someone is drowsy, you can take it in mouth and like good voice as well. So which institution?
Abbas, can you please stand up?
आप अवेस हुई अवेस नहीं मेरा तो दूसरे का काम है चलो ठीक है वो कुछ लोग तुम खुश मेरी शादी में शर्मंदी चली है उसमें भी नंबर आएगा मेडिकल हो हाँ जी मेडिकल के 10 मेडिकल ट्रीटमेंट क्या
ये क्या चीज़ कवर करना है?
मेडिकल ट्रीटमेंट क्या होगी किडनी स्टोन का मरीज आपके पास आया है साथी में क्या वो भी आता किडनी लेवल तक तकलीफ में आ गए क्या लोग क्लिनिक में बैठे हुए मरीज बड़ी उम्मीदों के साथ आप आते हैं उसको छोड़ दो क्या होता है इसका नंबर आएगा कि एक पेशेंट बहुत सीवियर पेन के साथ है और renal stone है तो हम इसको मैनेज करें और मैं आ गया वहाँ how you manage me? What are the people do? Right? Take a pen sodium उससे क्या तो पेंटिंग नहीं हो रहा है लोग में दे रहे बताओ इधर कोई चीज क्या नाम है
Sajid.
If less than 5 millimeter expecting treatment, watchful waiting is important. It will pass on its own. Very good. But next, but unfortunately, it is not less than 5 millimeter. It's more than 5 centimeter. Now what you will do? So you have to treat patient with the different treatments, like endourological management. Endourological, what he is saying that we will take it out through endoscope. What else? If that is failed, if that is failed, what next?
Open.
You have to do open surgery. You cut it out and take the stone out. अब बताएं भाई. ठीक है भाई.
So treatment mostly depends upon the site and composition, and it is mostly managed conservatively. There are some indications for early intervention if the patient has a irreversible pain, nausea, vomiting, action, fever, or acute renal failure and obstruction. We will approach some aggressively for early intervention. Next.
Treatment. Yeah, both speeds is there. What is the indication of strong indications of early surgery? Early intervention. Severe intractable pain. Infection will lead to destruction of nephrons, so you have to tackle it. Patient will have fever, patient will failure, and patient with bilateral stone. So if there is bilateral stone, they will block the urine formation. So patient will present with anuria. There will be no urine. Bilaterally, kidneys are compromised. So you have to do early surgery. Ensure drainage. Next.
So conservatively, we will manage mostly 90% of the stones less than 5 mm are passed spontaneously. So So we will advise only the bed rest and the application of balm to the site of the pain and some medications. We can give the analgesics concepts like diclofenac, ibuprofen, or indomethacin, ketorolac. And some strong analgesics are also used because this pain is very severe, like morphine, pepidine, nalmefene, or tramadol. And if the patient has a vomiting occur, then domperidone or metoclopramide may be used. And antibiotics are used in the infections.
In our country, I have seldom used morphine or pepidine in our country. Tramadol is quite prevalent, हम ये इस्तेमाल करते हैं, बाकी यहाँ पर हमारे पास नहीं है. Metformin भी हम यूज करते हैं, like pentaclacine or and ये last हो गए. बाकी ये दो medicines we do not use. हमारे पास नहीं. ये बस में दो हैं. This is the reason they are more indicated.
Then we can do some other measures like we will advise the patient to drink the plenty of fluids like 3 liters per day, and we can also do the IV hydration if the dehydration present in the patient. And there are 3 types of patients where the less water intake is used, like the heart failure patient, pulmonary edema patient, and the chronic kidney diseases.
So avoid even
And we
only are IV. IV hydration means infusion of saline.
we can also ask the patient to drink the lemon water without the salt to increase the alkalinization or the pH to reduce the acidity in the urine. And we can also prescribe the citrate or magnesium for the to inhibit the crystal formation.
So you might have seen that normally prescribed medication, citrol, citrate. And so then magnesium citrate. So they inhibit crystal formation. And lemon water without salt. Do not eat sodium chloride. Chapel salt. Yeah. Do not eat lemon water. This is good for maintaining urine pH alkaline. So patient will have decreased burning as well. If urine is acidic, it will burn the urine. Patient will have this urea, but because of acid. So it will convert it into alkaline medium, but it will be reduced. And this is the purpose of
Next. So there will be the medical expulsion therapy if the stones are 5 to 10 mm. It can pass with the medication, and 2 types of medication we will use. First of all, the tamsulosin, which is the alpha adrenergic blocker we can give, and second one is the calcium channel blocker nifedipine. And tamsulosin causes the dilatation of the lower ureter, and the bladder and the stone are easily passed. And the calcium channel blocker basically causes the relaxation of the uterine smooth muscle, therefore stone will pass
through the uterus, not uterine smooth muscle, ureteric smooth muscles. So alpha blockers, tamsulosin, they are uroselective. They will inhibit the smooth muscles of ureteric tract. So what is the commonest site of its infection? Urinary calculus. It is the hypo-urinary junction. So if you are prescribing tamsulosin, it should relax that end of the ureter and pass into the urine. So any stone that will pass from the ureter into the urinary bladder will easily be passed through urethra, because diameter of urethra is bigger than the diameter of urinary.
So we ask the patient to avoid all the meals that we have previously discussed, like the sulfur-containing proteins, meat, fishes, and like in the cystinuria. We can also prescribe the allopurinol for the hyperuricemia or the gout patient. We can also prescribe the penicillamine for cystinuria and diaphragmine. Chlorothiazide we can prescribe if the calcium stones are present, but avoid it in the dehydration patient because it can cause the dehydration. And we can also prescribe the veltromethazide for the idiopathic hypertensiuria. Then we can do the extracorporeal shock wave liquid. It is a non-surgical procedure, non-invasive, and it is most commonly used. But there are certain indications for this procedure. If the stones are present in the proximal ureter calculi or the lower pore or the calyces calculi less than 10 mm. Because in 1 centimeter, usually 10 mm are present, And if the stones are renal stones and less than 20 mm, you can do the extra
Less
carporial.
than 20 millimeter stone will be managed by extra corporeal shock with Pathri. तो काफी बड़ी range है. You see, less than 5 millimeter will be expelled, but more than 5 millimeter and less than 20 millimeter means 2 centimeter. So up to 2 centimeter stones can be managed by extra corporeal shock wave resistance. That's how you do extra corporeal shock wave resistance. अब देखें वो जो waves की कंपनी में बात बता रहे हैं.
Yes, sir.
Waves are traveling through that medium generated by this machine, and it will travel through the muscles, your skin, your fat, your muscles, perinephric fat, and the machine is focusing that wave directly over the stone, and that is going to disintegrate it. Fragmentation and disintegration. It will shatter the stone. Right? And the outer layer will be gone. Then next session another wave, and later on it will be destroyed. But if the stone is very hard, it will not be shattered. Next.
There are some contraindications for the extra corporeal shock wave epilepsy. For example, in the pregnant lady, uncontrolled bleeding, that's diathesis, anticoagulation therapy, uncontrolled hypertension, diabetes patient, urinary tract infection or urinary tract obstruction. So, can anyone tell what is bleeding diathesis?
What is bleeding diathesis?
Please stand.
बात करनी ऊंची बात करें भाई सीधे इन्हें ठोक के बात करें वैसे पीछे पीछे बैठ के क्यों कॉन्फिडेंटली बात करें सामने आके बात करें जिस दस से कोई मकतल में गया वो कॉन्फिडेंस के साथ बात करें गलत हो सही हो So clotting factors are deficient. ठीक है, liver is not producing proper clotting factors.
Thank you for
Coagulation factors are clotting factors. ठीक है, like hemophilia, statement, labile factor, Jackson factor. So how you are going to take the stone out?
So next procedure is the percutaneous nephrostomy, and in this nephrostomy needle is passed and the guide wire is passed into the renal pelvis and stones are removed, and then after this procedure we will insert the double gauge stent to reduce the urinary obstruction or ready.
So this is known as ECN.
Subcutaneous nephrostomy artery.
Nephrostomy or subcutaneous nephrostomy. You have to puncture it with a needle, help needle. So, but you are in the pelvis, and meanwhile, urinary catheter is inserted. You inject local saline from urine blood through their catheter. What will happen if your needle is in the urinary pelvis? What will happen? Saline will come out through your needle. Plunger आपने निकाल दिया. Now what you will do? You will pass a flexible wire into that hub of the needle. Then move it down. So the wire will go into the urinary. And then what you will do? You will hold the wire and take the needle out. Keep the wire inside. Now what you will do? Now you have to dilate the tract by putting dilator over to railroad the dilator over the guide wire. So it will make this tract bigger. Then meanwhile you have to insert the scope into the kidney and directly see stones in the kidney, and you break it and take it out. And this is known as percutaneous nephrostomy. So this is a kind of minimal access surgery. Only 2 to 3 centimeter incision is made here. Without making a big incision. This is known as PCNL. Percutaneous nephrostomy.
There are some indication for this procedure. If the emergency stone blockage is present or the extracorporeal shock wave epilepsy is created and the largest venous stone is present, if And if the obstructive anuria is present, if the pyelonephrosis, hydronephrosis, bilateral obstruction, or acute kidney is present. And mostly the renal stone greater than 20 mm and the proximal ureter, lower core, and the calluses greater than 10 mm are removed by this procedure. Next.
It was truly exhaustive sort of thing.
अभी रहते हैं ज़रा और आप
क्या कहते हैं इतनी जगह कहाँ है दिले का कह दो इन हसरतों से इतनी जगह कहाँ है दिले
मांग कर लाए थे जिंदगी की चार दिन और
very detailed and very informative, not necessarily being digested or absorbed by you people. ठीक है और चीज़ें बड़ी काम की जिसको अच्छा एक और अच्छी सी फीडबैक दे दें एक इधर से और एक इधर से कौन है ताहिर ये ताहिर को छोड़े ये लड़का ठीक
कैमरामैन पथरी वाले के साथ
नहीं करा था ना
ठीक है तो ये और भी 4-5 बातें थी करके इसका बहुत अच्छा था ठीक था लोग किताबें जल्दी छोड़िए कंटेंट पास होगी सेकेंडरी ही वाज कॉन्फिडेंट का ये ख्याल है उन्होंने ये बता दिए और दूसरी क्या बताते थे हाँ आई कंटेक्ट इसका था इंटरेक्टिव था इसका ये इनकी ऑब्जर्वेशन है यू कैन डिसएग्री अच्छा हाँ भाई आप बताएं अच्छा मैं कोई प्रिंट की बात दूर तो सारा काम हो गया कोई टेक होम मैसेज भी होता है कि जिंदगी में उसका कुछ फायदा भी हो क्या जिस आपके ख्याल में आपने कहा नहीं वो बात जमी नहीं
सर ये ज़्यादा टाइम रोस्ट्रम के पीछे ही रहे हैं स्टेज ऑक्यूपाइड
रोस्ट्रम के पीछे तो वैसे नहीं रहा है अच्छा दूसरा
बाकी सर नॉलेज के ऊपर कमांड थी जो पढ़ा रहा था मतलब उसके ऊपर फुल कमांड थी
हाँ उसको पता था कि मैं क्या बता रहा हूँ
यस
लेकिन एज ए टीचर मुझे थोड़ी सी रिजर्वेशन हुई है
सर रेडियोलॉजिकल फाइंडिंग पे उस टाइप की मतलब उस लेवल की नहीं थी कमांड
अब तो किसके लेवल की आपने बहुत ज़्यादा नहीं दी है वेरी गुड अच्छा मेरा ये ख्याल है कि इसकी फर्स्ट 2 मंथ
Yes, sir.
बहुत ज़्यादा स्टफ किया आपने स्लाइड कितनी लाइनें थी मोर देन 10 12 आपके पास जो स्लाइड्स होनी चाहिए नॉट मोर देन 4 और पिक्टोरियल है जो ज़्यादा हो बाकी तो आपने डिस्क्राइब करना है बाकी कोई ऐसी चीज़ तो नहीं एंड ज़्यादा उन्होंने वैसे उस बोर्ड से पढ़ा है स्क्रीन से आपने पढ़ा है आपको बेसिकली खुद पढ़ना चाहिए यहाँ से स्क्रीन से पढ़ना और ये जो है ना आपके पास होनी चाहिए ये के पास लेकिन ये पता नहीं किसी को उसका दिमाग उसका हो जाए बिल्कुल आपको खराब कर सकते हैं ठीक है रिश्ता गम को संभाल रखा है ठीक है आपने अपने निगम बना रखा है इसलिए आप अपना लैपटॉप अपने पास रखना और तीसरी बात बहुत स्पीड थी इसकी बहुत ज़्यादा स्पीड आपको तो पता है हम सबकी पता नहीं इधर बात और आपको रोकना क्या कहते हैं एक्सीलेटर
Break up.
एक्सेलरेटर पे हो रहा है
So generally it was very good. Very strong
माना
and I think we have had
बहुत स्पेस नहीं थी
Lotting objectives. ठीक है, ग्रेट ग्रेट।
जैसे आगे बजाता है